I'm very proud to give the floor to a well-known patient advocate to set the stage, Stefan Vernes. Verne. I knew I wasn't probably right with this. Is a member of the HIV Outcomes Steering Group and coordinator of the European Platform AIDS. Stefan, the floor is yours.
Thank you very much indeed, Madame la Députée. Ladies, gentlemen, good morning and bonjour. My name is Stefan. I'm a 50-year-old queer gay man who has been living with HIV for 21 years, 20 in the closet. I work for ED, the largest HIV NGO in Europe, and I'm a very proud steering committee member of HIV Outcomes, representing community-based organizations. It is not without emotion and pride that I'm talking to you today in this parliament full of history. In order to end the HIV epidemics by 2030, there are many things we need to address. We need to keep promoting U equals U, undetectable equals untransmissible, meaning that people like me with a stable undetectable virus load don't pass on the virus anymore. We need to keep saying it over and over, louder and louder. We also need to keep promoting and making available the pre-exposure prophylaxis, PrEP, in order to stop key populations from getting infected. We need a stronger political engagement on that. And obviously, we need to stop the discrimination of trans people, sex workers, and drug users, and more widely, LGBTQ plus folks, not only in Qatar, but everywhere in Europe. For someone living with HIV, the world is a tough, tough place. But so is my gay and queer community. When I turned 40, as an HIV positive person, I became invisible and rejected on dating apps. For many years, I came across people who made me feel guilty from contracting HIV, a shameful and dirty virus. This has left scars, and it took me 21 years to be at peace with myself. Some folks never recover. But HIV stigma is not only about for older people. In July, I was on a panel at the International Health Society Conference in Montreal, organized by EATG with Shiva. And I was listening to two wonderful young ladies from London, aged 17 and 19, telling us the stigmas they were getting from other peoples, even their friends, from the teachers, and from the school as a whole. All routes are different, and I can only speak about mine. However, some things link us together, and that is discrimination, stigmatization, and comorbidities management. Finally, I want to say that in 2022, we also need to improve the quality of life of people living and aging with HIV. In my country, France, in 2020, 50% of people living with HIV were 50 years old and over. This is me. Stable virus load is not enough anymore. We deserve to live well, we deserve good health care, we deserve brilliant sexuality, we deserve better and affordable treatments. We want to be able to look after our mental health, as many of us have suffered from discrimination because they live with this virus. Indeed, our lives are generally better than they were in the 90s. However, there is no place for complacency. In conclusion, 1st of December is a special day for people living with HIV. It's our day. I want to thank my colleagues at HIV Outcomes to allow me to take the floor to make this introduction. I do hope the event will bring us one step closer to addressing the challenges faced by people living with HIV and improving the health-related quality of life. In the Denver Conference in 1983, some gay men dying of AIDS were saying, if you can't do anything for our lives, at least listen to what we have to say. Health systems must monitor the health-related quality of life of people living with HIV. And as you said, today more than ever, it's nothing about us without us. The fight goes on. Thanks for listening.
Merci beaucoup, Stéphane, puisque vous êtes français,
oui.
finalement. And thank you so much for these very powerful words, for sort of setting the tone, and for that so long-standing commitment, of course, and obvious. This year, oh, I'm sorry.
Okay.
I hadn't seen it.
And because it's the 1st of December, we want to remember our sisters and brothers who died of AIDS over the past 40 years. So I'm going to ask you kindly to stand up.
Thank you. I was also going to say that this year's gathering conference is very important. We also have received the important patronage of the Czech presidency, Czech presidency of the European Council. It's a recognition, I think, of all the work that has been done together over the years, a guarantee of support also, and a close attention, I must say, to everything that's going to be said today, all the debates we are going to have together. Now, another sign, because you said it, Stéphane, that your voices have to matter. Listen to our voice. That's what they've been saying since '83. Another sign that your voice matters is the participation of the European Commissioner for Health, Stella Kyriakides. She couldn't make it physically this morning to be with us, but made it a point to record an important and short video message for us and for this very important day. So I propose that we listen to our Commissioner.
Dear President, honourable members, ladies and gentlemen, every World's Day we mark one more year of action against the AIDS epidemic. One more year of collaboration and determination from stakeholders and health professionals and from important organisations like HIV Outcomes. Today is all about you, patients, activists and experts, about committing to work with you for a future where people living with HIV no longer experience stigma or discrimination within health systems. So I'm delighted to be part of today's event, and I'm proud to stand alongside you. HIV Outcomes has a simple but powerful vision, one that I think we could all adopt. A world in which people living with HIV enjoy the highest possible health-related quality of life. In this future, we focus on the person and not the disease. In this future, it is not enough that people with AIDS live long lives. They should also live healthy and fulfilling lives, free from stigma and discrimination. If this is our shared ambition, then the new HIV Outcomes Policy Asks and recommendations is an important step in the right direction. Since the beginning of the COVID-19 pandemic, global progress against HIV has slowed, and the resources have shrunk, putting millions of lives at risk. Now we need to get back on track. Access to healthcare is a fundamental pillar of this work. Under the European semester process and via the Recovery and Resilience Facility, we will foster access to health services in member states. Community services are another important pillar, and the Commission is investing €7.5 million under EU for Health to help people affected by HIV, hepatitis, and TB to access quality services. And collaboration is a third crucial pillar. The HIV/AIDS community knows this very well. The Steering Group on Health Promotion, Disease Prevention and Non-Communicable Diseases will soon be replaced with the new Expert Group on Public Health, covering chronic and communicable diseases, including HIV. In September, the Commission pledged €715 million for the Global Fund to fight AIDS, tuberculosis and malaria. And Team Europe is contributing more than €4.3 billion to the Global Fund for the period 2023 to 2025. Ladies and gentlemen, we must address the inequalities that are holding back progress in ending AIDS. Inequalities around availability and access to services, around stigma and exclusion, around the sharing of technology. And we must focus always on the most vulnerable groups. So I wish you a successful conference. I look forward to working with you to enhance long-term health and well-being for all people living with HIV.
Thank you so much to the Commissioner. And knowing her a little bit, I know it's not only words. It's a very sincere support and personal commitment coming from her. So thank you again for a strong leadership and that continued support to the HIV outcomes. I will now, as I said previously, turn to the European Centre for Disease Control, which is hopefully with us connected online from Stockholm. When the Parliament decided to commission a study last year on the situation of HIV in Europe, ECDC came forward. They have a long-standing, should I remind this, expertise and commitment to the cause. They responded to our requests in a record time, and for that we have to thank them again and again, and this is why I'm particularly happy and honored to give the floor to Dr. Anastasia Faris to present, I can hear her, I think, an overview of the current situation, framing our upcoming discussions on the policy ask. Dr. Faris, you are ECDC's principal expert on infectious disease and the main author, actually, of the background paper. You have the floor from Stockholm.
Okay, I think you have to say.
Hello and good morning.
You
from
are
Stockholm.
connected. Yeah, good morning. Good
we
morning.
have lost the audio, so we can't hear so well on this side since sort of the end of Stefan's comments. But can you hear me?
Of course, we can hear you,
okay.
and we are listening.
We'll wave in that case, and hopefully we can solve it on the side as long as you can hear well. And can you see the slides?
Yeah.
That
Also,
we're sharing. Great. Okay.
everything TikTok.
Thank you so much and good morning. We really appreciate the opportunity from ECDC to participate in this event, and we'd like to thank MEP Rees as well as MEP Serdas and Pitikainen's offices for inviting the ECDC and the HIV Outcomes Initiative for planning this. Today, we wanted to bring you just a really quick snapshot of the situation of HIV in our region based on publications that came out yesterday, our surveillance and monitoring data, and then to present some of the results from the special report that MEP Rees referred to, which we had the honor and pleasure of contributing to, where we pulled together some information on health-related quality of life in people living with HIV, focusing a lot on stigma, as well as some other issues impacting quality of life and impacts that we've seen and that we can measure of COVID-19. This report is just now being published, and it's been a great opportunity for ECDC to take stock of what we know and actually what we don't know around these issues in Europe, and kind of help us to direct our efforts toward where we need to work more together with our partners in the future. So just zooming out into the latest snapshot of the new numbers that we published together with WHO, we do this for the full European region, and the numbers for 2021 were still over 106,000 people diagnosed in our region in 2021. Over 16,000 of these in the EU. For epidemiological purposes, we divide our region into 3 areas because there's been similar epidemiologies in West, which is green, Center, which is blue, and East, which is yellow. And have found that, as in past years, the majority of cases are in the east of the region, 78% of those, and the rates do differ substantially across our region. Across all of the parts of the subregion, including the EU, more than half of people are diagnosed late, and this is an issue which impacts morbidity, mortality, and quality of life for people living with HIV around the time of diagnosis. There are new targets from UNAIDS, and I think we've heard a lot about those, especially now around World AIDS Day. So the 90-90-90 that we were focusing on a lot, and which the HIV Outcomes Initiative has encouraged us to broaden and extend to include additional measures of quality of life, have now been reworked, and we should focus on 95-95-95 by 2025. But there's also been some helpful greater acknowledgement around issues of quality of life and patient-centered care, which I'll touch on later. For the first classical 90-90-90, we monitored those going up to 2020, those targets. And for the 2.3 million people living with HIV in our region and the over 760,000 in the EU, we pulled together sort of how our subregions are doing on those first 90-90-90 targets. 90% diagnosed, 90% on treatment, antiretroviral treatment, and 90% virally suppressed. And there we see that in the West, one of the targets has not been reached, and that is the diagnosis target. So we need more focus on that going forward. In the center, there is sort of a lag behind on both diagnosis and placing people on treatment quickly after diagnosis, and in the East as well in those areas. In the EU, we see the same picture, that we need to work more on diagnosis, but there is room for improvement in all areas. But if we turn to these new targets, where less than 10% of people living with HIV and key population should experience stigma and discrimination, we look into the sub-goals there, which are helpfully outlined by UNAIDS, that people living with HIV should not report, or less than 10% should report stigma in different situations. We at ECDC, together with our partners, realized that we don't have really clear tools or an initiative to measure this across Europe in a consistent way. And this has always been a challenge because stigma can operate across settings and across people, of course, but nonetheless, if we don't measure it, we know nothing. And so together with partners at EATG and AIDS Action Europe, my colleague Tamer Nouri has led a project on measuring stigma in the community to try to fill some of these gaps. And I'll speak a little bit about that today. We also have ongoing discussions with the European AIDS Clinical Society and IAPAC for a similar twin initiative to measure stigma in healthcare settings. So we do hope to fill a lot of the data gaps that we currently see in Europe with these first pilots, and then trying to improve on this going forward. The stigma survey in the community was launched and promoted by EATG and AIDS Action Europe and many community organizations across Europe, and we're really grateful for that. It was promoted about a year ago and was open over the Christmas holidays, so we prolonged it until January of 2022. We received over 3,000 responses. Many of those who responded were on ART, and the majority were self-reported as MSM, and the majority were men. We were really happy to have responses from over 54 countries, and so did get quite broad participation from across Europe. There were quite a few questions asked. One was a life satisfaction score. And so this gives, of all respondents, the 17% had very low life satisfaction scores, so indicators of less happiness with certain aspects of life. And we use that to then sort of cross-tabulate or compare to other things that people reported. Some questions focused on different responses and agreement with certain statements. And so we found that over a quarter of those responding agreed with the statement, "I am ashamed of my HIV status." Over one quarter felt that they had poor self-esteem because of the HIV status. And more than half said it's difficult to tell people about my HIV infection. When one of the questions was on who have you told that you have HIV? And quite a few people had indicated to friends, family members, and current sexual partners, to nearly all or the majority. But worryingly, more than a quarter had not told anyone, or had just told one or two people in their family or friends or sexual partners. So really, this was higher than we'd expected, and pointed to the need to look at how this is operating in people's lives and impacting their well-being. Also really, really worrying, a lot of people had experienced either more recently or further time ago, rejection by friends and family members, threats, discrimination, from people that they know, and verbal abuse, etc. And so again, very, very worrying results to see this reported in our region. We also asked about the experience of people in stigma in healthcare settings, and also saw still even higher levels of reported stigma in different contexts with healthcare. And so this is something that we do need to address, and are going to survey healthcare providers, but also try to understand how can we impact this, and what types of approaches may help to address this already at the training level for nursing, medical, and dental students, and then throughout their practice. We saw that there was higher stigma reported in people who rated their health as more poorly, and also those who had markers of depression in the last 2 weeks. So we can't, of course, say which direction if the stigma caused this, but there's definitely a strong association. Also in the survey sample, those members of key populations, all members reported substantial stigma, but it was higher in people who had been in prison and reported sex work. And so this is just the beginning of our work at ECDC on this topic. We will continue to improve this, and to try to find ways to standardize the measurement of this and improve the measurement of this across Europe, both in community and healthcare settings. I don't have time to touch in detail, but the report does go into a bit more detail on the fact that there are, Stefan mentioned already some of these, that there are impacts on quality of life that go far beyond stigma. There are higher rates of co-infections in people who are living with HIV. Some of these are well known, such as TB, hepatitis C, and hepatitis B. But there are also other co-infections that maybe we don't talk as much about. And more recently, we don't call it co-infection, but we saw a large association, for example, in the monkeypox outbreak in people living with HIV, maybe due to more testing, but things that we need to keep our eye on and ensure that good care is being received in this population. High prevalence of comorbidities and multimorbidities, partly because of the aging population of people living with HIV in Europe. And so attention to the whole person centered care around non-communicable disease, and also around mental health care is extremely important. I also wanted to mention legal restrictions. This is all in countries outside of the EU, but there are still 48 countries globally that have restrictions on travel, on living, on work or travel visas associated with HIV status. And this, of course, impacts people's ability to participate in events, and also as global citizens. One of the UNAIDS targets is that 90% of people living with HIV should be linked to people-centered and integrated care by 2025. And so what does that mean, and how can we improve that, is something that we need to discuss with our community and clinical. What are ways that we can measure this? What does this mean for us in Europe? When we looked at what countries were including health-related quality of life measures, and we'll hear a bit about that more later today, we found that very few countries were actually including these. Probably, I think it was about 8 of the EU countries had any type of health-related quality of life measure used at all. And few of them, I think only 3, were using patient-reported indicators or outcomes monitoring. So there's a lot of room for improvement in standardizing and improving the measurement in these areas. Finally, just some words on COVID. We know that this impacted our society a lot over the past couple of years. And during the more intense time of the pandemic in 2020, ECDC did a survey of EU countries, but also of the wider European region. 40 countries responded, and many of them had closed or severely reduced services during that time in the pandemic during 2020. This included prevention services, but also HIV treatment and care services. We know that it did impact service provision, with 7 out of 10 countries reporting reductions in prevention, 3 out of 4 countries reporting reductions in testing, which could impact late diagnosis, and half of countries reporting a reduction in the provision of HIV treatment and care, which could have impacted health outcomes and viral suppression, as well as the wider wrapper care, social work visits, mental health support for people living with HIV. We also did hear anecdotally of some good examples, going more to telemedicine, which I think we need to explore more with regard to how this has impacted patient satisfaction and whether this provides opportunities for different types of care and interaction with healthcare providers going forward. So in conclusion, in our wider conclusions based on the HIV epidemiology in our region, we see there's a lot of room for improved prevention. We haven't spoken so much about that today, but that is important to ensure that people are receiving adequate prevention, pre-exposure prophylaxis, and harm reduction services. Testing has been a persistent area that we've highlighted as an issue for the EU, but also beyond, where half of people are diagnosed late and many people are living with HIV but unaware of their status. We still have a lot of people who are diagnosed and not immediately placed on treatment in Europe, despite the fact that European AIDS Clinical Society guidelines and most national guidelines recommend this. And so ensuring that rapid linkage to care, it remains essential. But also looking at the stigma gap and the high levels of stigma that we have seen detected in the community sample, as well as the reports in healthcare settings. So improving measurement of that, but also addressing this to improve the situation. So concerning, and just to repeat, 1 in 6 people living with HIV that we surveyed had not told a single friend, or 1 in 4 had not told a single family member that they had HIV. The stigma that we found was highly prevalent, and greater efforts are needed to address this. There's also a strong need to consider how quality of life and health-related quality of life data collection can be standardized across our region to allow comparison of data between countries, and this is something we at ECDC are committed to work on. Integrated patient-centered and patient-involved services will be important to promote health-related quality of life, and we think that further discussions around what this means and how this can be measured and promoted would be helpful. And continued attention to assessing the long-term impacts of COVID-19 are important, both on HIV services and health-related quality of life for people living with HIV. So I'd like to end by thanking in particular my colleague Tamar Nouri, who's led a lot of the work that I presented today, as well as colleagues at many different agencies across the EU, particularly EATG and AIDS Action Europe, who promoted the survey and were partners with us in the survey. Thank you so much, and looking forward to the rest of the discussions.
So thank you very much, Anastasia. That was a really very comprehensive overview and has set the scene extremely nicely. We will be circulating the report and the presentation in the materials that go to you after this meeting. I'm sure it will be a very, very useful tool. I'd like to thank now Frédéric for your unstinting commitment to the work that the HIV Outcomes undertakes historically, but also moving forward. This really means a huge amount to the community. Thank you once again. And I'd like to thank Stefan in particular. This was a really vibrant and meaningful session. And thank you. And thank you. And thank you. And thank you. Lots of thanks. If you'd like to take a seat with the audience, that would be wonderful. Thank you. Thank you. And I'd like to welcome Professor Guaraldi and also Anton Bazenko to the podium, please. We're now going to move to the next session of the meeting, and we will explore and indeed launch the HIV Outcome Policy Asks. And I'd like to give a warm welcome to Mario Castillo, HIV Outcomes Steering Group member and EATG Quality of Life Programme Chair, and Mario is joining us online, and he will share with us the rationale behind developing the policy asks, the process that led us to today's launch, and actually he will also expand on the pillar of the policy asks that focus specifically on stigma and discrimination in healthcare settings. We've already heard this morning how critical that is, how pervasive it still is in the 2022, I meant to say. So please, the floor is yours to talk us through a little bit the context and the history.
Good morning, everyone. My name is Mario Cascio, and as a steering group member of the HIV Outcomes Initiative, I will be introducing this session. In November 2017, here at the European Parliament, Good morning, everyone. Good morning, everyone. As a steering group member of the HIV Initiative.
So technology is not on our side today.
In November 2017,
can I have a quick feedback from the technician on where we are? If not, we're going to move forward because we're already a little bit behind time.
Health, well-being, and chronic care for people with HIV. Now, 5 years on, we are here to launch our updated policy asks that focus on the continuing challenges and gaps in care for people with HIV.
I think it was more or less acceptable. People could hear.
Good morning, everyone. My name is Mario Cascio, and as a steering group member of the HIV Outcomes Initiative, I will be introducing this session. In November 2017, here at the European Parliament, HIV Outcomes launched its recommendations on long-term health, well-being, and chronic care for people with HIV. Now, 5 years on, we are here to launch our updated policy asks that focus on the continuing challenges and gaps in care for people with HIV and identify areas for action. This is the result of a one-year process and collaboration between our European Steering Group members, our HIV Outcomes in-country representatives from Germany, Italy, Romania, Spain, and the UK, and our HIV Outcomes General members from across the WHO European region. The policy asks were developed by a multidisciplinary group of experts and included balanced participation of 60 organizations and individuals representing people with HIV, clinicians, academics, public health professionals, and industry. On behalf of the HIV Outcomes Initiative, I would like to thank all our members for their great contribution. Our policy recommendations aim to complement other initiatives that focus on HIV prevention, testing, universal access to treatment and care, including for migrants, refugees, and internally displaced people, and getting to zero new infections, zero AIDS-related deaths, and zero discrimination, where significant efforts are still needed in many European countries. This policy paper highlights 4 key areas where action is needed to improve the health and well-being among people with HIV. The identified areas are comorbidity prevention, treatment and management, aging with HIV, measurement of patient-reported outcomes and monitoring of health-related quality of life, and combating stigma and discrimination. For each key area, priority recommendations were developed for action at 3 different levels. At the level of HIV clinics and care providers, at the level of national and regional health authorities, and at the level of the European Union. I will be speaking about HIV-related stigma and discrimination. HIV still remains one of the most stigmatized diseases in almost every culture worldwide. An additional burden is given by the vulnerable to HIV often belong to groups that are already stigmatized by society. I remember in the early years of the epidemic, no one wanted to come near you, touch you, hug you, kiss you, or even sit next to you if they knew you had HIV. Of course, things have changed a lot since then, but stigma is still out there, impacting the lives of people with HIV, still today, in their physical, mental, emotional, and social spheres. Societal stigma and discrimination, including stigma within the healthcare system, can take on many aspects, such as refusal of care or suboptimal care, verbal and physical abuse, difficulties in finding a job or even losing a job, difficulties traveling with visas, getting insurance, getting a loan, people keeping you at a distance or sometimes even avoiding you, moral judgment, just to name a few. And addressing stigma within the healthcare system will be increasingly relevant due to the increasing need for many to navigate the healthcare system beyond the HIV clinic. In fact, stigma within the healthcare system can discourage people from getting tested and seeking healthcare services. Perceived or anticipated stigma is when people fear that they may be excluded or rejected. And internalized stigma or self-stigma is about the way people may feel about themselves, which can lead to feelings of shame, guilt, and low self-esteem, which in turn can lead to social isolation and a disconnect from society, and even from your loved ones, families, and friends. All of this certainly offers us a better understanding of the strong impact that the different forms of stigma can have on the lives of people with HIV. And HIV-related stigma and discrimination is certainly a barrier to achieving our UNAIDS targets. It can have a negative impact at each step in the HIV care continuum, starting from being diagnosed all the way to achieving viral suppression and achieving good health-related quality of life. It can be a barrier in seeking help, it can delay care initiation, it can result in poor retention in care, in poor treatment adherence, poor mental health, poor health outcomes, and poor quality of life. And I think we can all agree on the fact that stigma and mental health are closely interconnected. Of course, HIV-related stigma is not the only driver of mental health problems, but it is certainly one of the pathways to depression and poor quality of life. We from the HIV Outcomes Initiative strongly believe that combating stigma and discrimination will be key in achieving long-term health, ensuring good health-related quality of life, and reaching the UNAIDS targets, and have included it as one of our 4 pillars of policy asks. At the level of HIV clinics and care providers, we call for peer-to-peer and community-based interventions to address stigma and discrimination experienced by people with HIV, including a focus on the fact that an undetectable viral load means untransmissible virus. That means the so-called U equals U message. Community-based organizations have historically played an important role in supporting people suffering from loneliness and internalized stigma. People with HIV require support as they learn to live with their HIV, adhere to medication, access healthcare and community services, and cope with the stigmatizing experiences that they may face in their daily lives. We call for peer-to-peer services focused on key populations, including trans people, sex workers, people who inject drugs, and people in closed settings, to more effectively address and respond to the intersecting stigma and discrimination experienced by those populations. And at the level of national and regional health authorities, we call for the design and implementation of interventions that can strengthen empathy towards people with HIV among healthcare staff and decrease stigma and discrimination in healthcare settings. Monitoring and regularly reviewing the effectiveness of these interventions will be crucial. Provide training that enables healthcare professionals to detect and identify potential instances of discrimination in the lives of people with HIV. provide support and funding for interventions involving peers and community members. And finally, strengthen data collection and reporting on stigma and discrimination in line with UNAIDS monitoring. And at the EU level, given the negative impact of stigma and discrimination on mental health, ensure that any future EU mental health strategy includes a focus on reducing stigma and discrimination among groups at risk, including people with HIV. This strategy should adopt a societal approach to combating stigma and discrimination, in particularly among vulnerable groups and within health systems. The EU should provide guidance to member states on actions to combat stigma and discrimination, drawing on best practices from across the EU region. Thank you all.
Thank you very much. So we see we've got some very powerful policy asks in the critical area of stigma and discrimination. And we have Anton Bazenko, who will be able to answer any questions you may have when we go into the Q&A. We have a little bit more flexibility with the agenda, you'll be pleased to hear. We don't need to stop at 12:30. As we originally thought, we can move a little bit further towards 12:45. So we can bear that in mind as you think about your presentations and so on. So moving now then to Professor Jane Anderson, HIV Outcomes Co-Chair and Consultant Physician at Homerton University Hospital NHS Foundation Trust in the UK. Professor Anderson, Jane, a very warm welcome to you. It's great to have you here in Brussels. Let me ask about, first, the severe impact COVID-19's had on well-being of people living with HIV. And we heard about this a little earlier in our conversations, but particularly focusing on mental health. How can we actually ensure more policy oomph in that arena?
Well, thank you very much, and thank you for including. Oh, thank you. Thank you for your welcome and for inviting me to be part of this meeting. I'm speaking as a clinician. I've worked in the field for 40 years, on and off, and actually in those early days, everybody died. And our job as doctors was often to be effective palliative care physicians. So much changed with the introduction of treatment. And the concept of living with HIV rather than dying of AIDS became really real for us at that point. But I think the last few, the decades since then have shown us that living with HIV is not as simple as all that. And so we are seeing the arrival of more comorbidities, more difficulties, and the report from ECDC just now really covered, I think, in great detail and very beautifully a lot of the challenges. With COVID, a lot of things changed, and a lot of things changed particularly with service delivery, because clearly the ability to have face-to-face consultations changed, the workforce changed. A lot of people who were working in the field of HIV were seconded to work on COVID, and everything changed so dramatically. And I think that we saw certainly in the UK and in London, a lot of people who, you've seen from ECDC, so many people have told nobody apart from their healthcare providers, and then their healthcare providers are closed. How does that work? And the impact that had on people's lives was very, very profound. And we've had a lot of catching up to do. And I think one of the things we are seeing now is that people fell out of care during COVID because of all the other complexities that were coming along. And this is a really important issue to get back on track and make sure that people, the rest of whose lives were really complicated by COVID, are able to re-engage with care that might have been lost. And mental health was absolutely central to that and has always been a huge issue in relation to HIV. We know that people living with HIV, as Mario has said, have twice as much mental health morbidity as the general population. A third of people living with HIV have at some point had a mental health diagnosis, and poor mental health affects the entire pathway from testing, diagnosis, engaging with care, quite apart from its own problems. And we know that people with mental health problems also are at higher risk of HIV. So that the intersection is incredibly important, and stigma and discrimination make that all so much worse. So in terms of mental health care, I think one of the most important things is to ensure that we have adequate and appropriate mental health care for everybody, and within the HIV sector that the specialist aspects are available and addressed in partnership with the physical and the clinical care. And in our arena, that's often difficult because on the whole, healthcare is organised by organs and specialties and germs, and to organise it by people and people's needs is a real challenge, but we're moving in that direction. Mental health care has tended historically to be separated from physical care. So one huge ask is that we integrate, we join up, we work together, that interface between mental and physical care is dissolved and moves away. So I think that's a really important point.
Really, really key, this holistic approach, I think, and that again has run through some of the presentations earlier. Just coming to the policy asks that are being launched today, could you perhaps unpack those in a little bit more detail when it comes to comorbidity, prevention, treatment and management? We've heard about stigma and discrimination. Tell us about this specific pillar.
So this is incredibly important because going back to this point about us as clinicians, actually providing care that is enabling people to live and live well and live long is absolutely central. And that means we must pay full attention to everything that is happening for that person in a person-centred way. And so that requires us to ensure that we're screening and looking out for the other comorbidities that may be existing, that we're in a position to treat the entire range of things that may be happening to people living with HIV, and that we are integrating those strands. At the moment, we know people are having to have 6 different appointments to see the heart doctor, the HIV doctor, the knees doctor, the hepatitis doctor. How do we become much more focused so that we are able to do things together? And maybe some of the discussions we've heard about telehealth, remote working, offer us some new opportunities to think about how that might be. We have to understand what it is we're seeing. So capturing the data, and I know Jeff's coming to this in a minute, but we've heard from ECDC how important it is to know what it is that we're dealing with and to know whether we've got the right output. And crucially, in the midst of all this, to ensure that we have holistic person-centred care to make sure that the experience and the expertise that is lived by people with HIV is in partnership with the professional expertise, so that we ensure that we have peer support, peer navigators embedded within our clinical services. And that seems to me to be absolutely crucial. That, I think, is what we should be doing at the local level, and obviously providing that in a stigma-free environment. The idea that healthcare settings could be places where people with HIV feel unsafe is deeply shocking and has to change. We cannot have this as a situation going forward. So how do we do this at a national and regional level? Well, we're asking that there is a monitoring framework, that these indicators of integrated care are available, that we're using them, and that the actual frameworks that we're producing get integrated into those policy asks, that it's no good just doing it. It's got to go somewhere and fit in and make the difference we need to see. And I'm absolutely delighted, we've heard it twice today, that the European Union movement on disease prevention and well-being that was initially going to focus on non-communicable diseases has recognised that HIV is a long-term condition, that it has as much need for that input as non-communicable diseases. So we welcome that hugely at an international level.
Terrific, and I think Dr. Andriukaitis will be talking about that a little bit later on this morning. Fantastic, thank you very much, Jane. I'd like to now move to Professor Giovanni Goraldi, HIV Outcome General Member and Associate Professor in Infectious Diseases at the University of Modena and Reggio Emilia in Italy. A warm welcome to you, Giovanni. I know that you're going to look at the particular issues facing older people living with HIV, with a greater risk of developing disabling or life-threatening comorbidities, how healthcare systems are addressing this, and whether it's really prominent enough in the policy discourse in general population ageing. So I know you have a few slides to share with us as well.
Yes.
The floor is yours.
Thank you. Can I have my slides, please? How can I go on? I say, go on. Thank you. So these are my disclosure. And actually, in a few minutes, I would like just to discuss the next slides, really, what is aging in HIV, and actually, is aging different in people living with HIV, and try to move the knowledge we acquired in these years into action. Next slide. So I believe that all doctors, but also policymakers, should know that regardless of the incredible advances we obtain with regard of survival, of care, of people living with HIV, really older people, I'm speaking here people above the age of 65, really face a higher odds of having multiple chronic conditions. And this means that at any age, the risk of single comorbidities is enhanced, and this is true both for physical health but also for mental health. Let us show these graphs that were obtained for a large cohort from a Medicare database in which over 43,000 people aged more than 65 were compared to over 1 million people. And you can see that all the age-related condition, but also depression, is incredibly higher in people living with HIV. And unluckily, these have an impact with regard of survival. Next slide. But also we need to think that, in fact, older people living with HIV are a very dispersed, diverse population. In this study, we were able to show that any single comorbidities, but also multimorbidities, was much higher in people aging with HIV, that is, living with HIV for more than 20 years, when compared to people that acquired HIV more recently, but with the same age. And so, in fact, we need to understand that age itself is not enough to describe the complexity and the age relation with comorbidities. Next slides. But what I think is even more important is what we've learned from geriatric medicine, that is to say that the complexity of aging cannot be described by the accumulation of age-related comorbidities, but rather I need to introduce a new construct that is called frailty, that in fact tells me about the vulnerability of individual. And actually this beautiful study from Age HIV cohort, in which people at any age appear to have a higher prevalence of frailty. And actually each of the 5 domains that describe a frailty phenotype, like exhaustion, like an intentional weight loss, like loneliness, were in fact higher in people living with HIV. Next slides. But I think what is even more important is that the trajectory of aging in people living with HIV is different. On one side, we need to recognize that frailty is a reversible condition. Nevertheless, the switch from a robust state to a pre-frail and frail state is much more common in people living with HIV when compared to uninfected individual, but the reversibility is less likely in people living with HIV. Next slides. But what I think is really relevant is the message that WHO is now providing us, not to consider aging like just an accumulation of diseases, but like to think that we can have a healthy aging. To do so, really, what is important is to describe healthy aging, that is the possibility of well-being at an older age. And this introduces this idea of functional ability, that is a health-related attributes that really enable people to do and really to be able to engage age life according what you value. And this is very important because functional ability is the net result of two different aspects we need to keep in mind. On one side is intrinsic capacity. This is the biology of aging. This is my genetic inheritance. This is my comorbidities. HIV is inside here, but actually this relates with the environment. I cannot consider biology of aging outside from the environment, and really the interaction between the two will return to me the possibility to have a healthy aging. Next slide. The point is that across the trajectory of age, what we believe that the gap between intrinsic capacity and functional ability appear to be larger in people living with HIV when compared to the general population. And there's many aspects that makes this difference. Among all, we have already quoted today the issue about HIV stigma. But let me say, in the context of aging, there's also ageism, that is the ism, that is the stigma that is related to age. And we know that there is a strong intersection between HIV stigma and ageism that make people living with HIV experience more loneliness. Next slide. And so I believe it is time to consider a different way in which we deliver care. This is true for HIV in general, but is particularly true for older people living with HIV. Remember, there are still too many people that arrive to HIV diagnosis at a late stage, and particularly very few older people are offered an HIV testing. And this is incredible to recognize that having access to a diagnosis is so difficult in older people. Of course, when I take care in a person-centered model, I will, first of all, try to obtain undetectable viral load, and the paradigm of U equal U is so much important also for all the people that maybe even be less aware about the risk of HIV transmission. But of course, I needed to take care about co-infection and comorbidities, and we know that comorbidities will accumulate in older people, and this means a strong impact with regard of polypharmacy. And polypharmacy, at my clinical perspective, is something we need to work more and try to address. And really, we needed to think that social support is pivotal in older people, especially in the context of the loneliness that they do experience. And we need also to do a task shifting, to teach HIV physicians how to assess functional status assessment and the geriatric syndrome, especially frailty, in the context of older people living with HIV. Next slide. I think this document that has already been quoted today is so much important also in the context of aging. First of all, as far as I know, this is the first document in which health-related quality of life is presented as an outcome, okay? But also this idea of a patient-centered health service gets into the possibility to consider HIV in the context of other chronic non-communicable diseases condition. This will allow to gain resources from the environment. And so it's so much important for me to know what's the community really is offering me for older people, for disabled people, and try to put this in the context of managing older people with HIV. This is even more important when I think among older people, special group, imagine for instance, transgender people, people who live in jails, in which this need is even more important. Next slide. This is to say, I've got an optimism because this is an image that I believe to be an icon of the possibility to reach healthy aging with HIV. This is a guy I met in Lisbon. He's been living with HIV for more than 30 years, and he died at the age of 100 years. The issue was not being able to live 100 years, but the possibility to arrive of 100 years not disabled, to die in his own bed, and not having multimorbidity on polypharmacy. And I believe this in mind is something that we can achieve for all our people living with HIV. Thank you for your... Oh, sorry. Let me end with say, what are the messages? This is the most important slide. And really the message is really, what can we do at a clinical level, at a national level, and of course at an European Union level? Well, first of all, I told you about the necessity to study more, to having funding for pilot study. This is really important in order to develop a framework, to put a geriatric construct into the possibility of managing people with HIV. But also at a national level, we need to implement a training program and for also careers, and in particular for working in a setting in which they are not used to take care about people living with HIV. Imagine how it's still difficult to have people living with HIV inside home-based care for older people. And but let me say, at an European Union level, and here we are, we need definitely to have the possibility to have more funding in order to have studies that will allow us to provide better care for the future. Thank you so much.
Thank you very much for translating your very powerful messages and obviously research and so on into the policy asks, the really very concrete policy asks to move forward on the issue of ageism and ageing with people living with HIV. And I think we'll all remember the Lisbon person and the dignity linked to the Lisbon person and the optimism that that actually demonstrates as well. So finally on the panel, let me welcome Professor Jeffrey Lazarus, HIV Outcomes Co-Chair and also head of the Health Systems Research Group IS Global at the Hospital Clinic, University of Barcelona, Spain. Thank you very much, Professor Lazarus, Jeffrey, for joining us today. The merits of health-related quality of life are clearly well known, but the concept is only just beginning to enter health policy and practice beyond the area of clinical trials. So why, in your view, has that actually taken so long to gain momentum? And are problems actually in this space perhaps very difficult to navigate? What's your sense on that?
Well, thank you, Nicola. Thank you, Nicola. You know, arriving here today, you know, after such a difficult couple of years made me also want to reflect. I mean, HIV Outcomes has been advocating for improving the health-related quality of life of all people living with HIV, you know, for over 5 years since our founding and when we sat here on World AIDS Day in 2017. And I don't think we imagined that, you know, we'd arrive at a time when just yesterday, you know, the ECDC, as Anastasia Ferris announced, launched, you know, their report and their study on health-related quality of life, very much thanks to MEP Rees and her colleagues for commissioning it. And it's such an interesting report because it comes from a specialized agency of the European Commission, but was co-developed, you know, with the community and led by leading epidemiologists. So it's taken a while to get HRQOL on the agenda, but it's getting there thanks to champions. Also, as Giovanni showed, in the new WHO Continuum of Care, there's still the main points that we remember from the 390s. But if you look at the bottom, you know, go into that report, look for that figure. The bottom bullet point says one of the outcomes we need to measure is health-related quality of life. All member states agreed to that at the World Health Assembly in May 2022. So this is really a landmark year for health-related quality of life. Now, one thing is it's in the policy documents, but as you know, we also hear because we have a number of policy asks, you know, which first and foremost is related to following up on that. But I mean, why has it taken so long and how long has it taken? Well, it's taken since at least 1948 when WHO launched their very enduring definition of health, which puts a focus on not merely the absence of disease or infirmity, and it is worth always repeating this, also a focus on well-being, mental, social, and physical well-being. So key aspects of health-related quality of life have actually been on the policy agenda for over half a century. Now they're on the ECDC, the Commission's, and the WHO agenda. We need to make sure that it doesn't go another half a century before we actually start to implement them. You asked about PROMs, patient or person reported outcome measures. This is how we know how well people are doing on health-related quality of life, because earlier HRQOL was very much associated with the treatments, associated with the clinical trials, and now, as we've been hearing from every speaker, we need to listen to people living with HIV so they can tell us how well they're doing, not just in terms of physical well-being, but also in terms of the social and mental well-being that WHO called for already back in 1948. Our experience in HIV outcomes is really that very limited progress has been made on the integration of PROS into routine HIV care. So there are the studies that people like Professor Guaraldi and others are leading across Europe, are leading around the world. There's been great initiatives in England, in Sweden, in Australia, but that's just a few countries around the world that have really taken it seriously. And we know that a few years ago when this was measured by the ECDC, only 5 member states reported actually tracking HRQOL. So it's taken a long time. It's on our agenda. We know it's important, but we have to do something concrete about it.
Terrific, and that actually takes me to the policy asks that we're launching today in terms of measurement, in terms of monitoring. Can you just walk us through what it is we want to move towards? And of course, the key thing is implementing, and what gets measured gets done, of course.
Sure, and I mean, as you see on the screen, as Mario already mentioned, we've divided this up into 3 main areas. So importantly, at HIV clinics and the care providers level, because when we speak to clinicians, they ask us, what can we do about this now that we have national level data? Well, at the clinic level, it's urgent that person-related outcome measurements, PROMs, are fully integrated into clinical practice, which can then be used for shared decision-making with those living with HIV, tailoring interventions to individual needs and preferences, and monitoring health outcomes over time. At the national and regional levels, we need annual surveys of people with HIV, collecting the data on HRQOL, on their experiences with stigma and discrimination. I mean, it's not just being based at a research institution that I want to see more studies, but we know we need that data. It gives us a baseline, it allows us to compare between countries, and it allows us to target our interventions over time. And finally, as we've seen and heard, the European Union has a crucial role both in allocating funds for the inclusion of HIV within the OECD Paris Initiative to provide standardized, comparable data on PROS and experiences across countries, but also to be able to commission reports from their specialized agencies to get the parliamentary resolutions we need and to monitor over time so we can go back to the countries, see how we're doing based on listening to people living with HIV.
Fantastic. And I know from my own experience that the OECD Paris Initiative has made a lot of effort to involve and engage the community with patient-relevant outcome measures, patient-relevant experience measured as well. So that's terrific. Thank you very much, Jeffrey. So now's the time to open up with any questions, comments, thoughts from you as participants. Please.
Thank you. I'm Federico. I work at the European Parliamentary Forum for Sexual and Reproductive Rights. I represent members of parliament and from the European Parliament as well, who protect sexual and reproductive rights, both in their national parliaments and abroad. First of all, congratulations on the policy recommendations, and we will be sharing them with our group of parliamentarians, of course. I have 3 points. The first one is 3 things that perhaps weren't really mentioned, and we could maybe go deeper now. The first one is, I thank you for the gender sensitivity that the recommendations have. There is a reference to women, and we know that people in 2022, we know that women living with HIV have different needs, and there is this focus in the recommendations. I think it's just great. The second point is, maybe I read it, I didn't have time to read it in depth, but I didn't see any reference in as a recommendation to health authorities to remove financial barriers. And I'm thinking of specifically of HPV prevention. We know that people living with HIV have 120 times higher rates of having anal cancer, and we know that science shifted from talking just about cervical cancer to cancers, and 30% of people living with HIV die after getting diagnosed of anal cancer. So this is the second point. And the third point, just a remark, you talk in the last part of the recommendations about awareness campaigns and just trying to be more empathetic with people living with HIV in the campaigns. It's just food for thought for everyone in the room. I'd like to challenge you and just go see what your ministers of health in your countries have been publishing today for the World AIDS campaign, because I think I come from Italy and I can relate for my country. I think there is still we still need a human rights-based approach. It's 12:05, and my minister has just published something related to infections. We don't talk about U equal U. We don't talk about PrEP. We don't talk about treatment as prevention.
I think we've got your point. That's fantastic. Thank you for those three critical comments. I think Jane would like to come back briefly on that.
Yeah, and thank you very much for the question about sexual and reproductive health. I think it's incredibly important. And I would just remind us of the slides we saw from ECDC that 98% of those responses were from men. And it's really important that we capture what's happening in everybody's lives and quality of life across the piece. But sexual reproductive health seems to me to be incredibly important and linked very closely to the need to ensure that we have holistic, joined up, integrated care. So ensuring that we have clear pathways and linked up services, particularly thinking about reproductive health rights in terms of contraception, fertility. We have a campaign at the moment in London, in the UK, Blood National AIDS Trust, on fertility rights, which we know still are needing attention. Menopause, incredibly important. And you know, as Giraldi was talking about aging well, certainly when I was starting my clinical career, women weren't living long enough to experience the menopause, and now, of course, and we haven't yet quite got the skills, but that is such an important area. And the need for appropriate peer support, I think, is incredibly important here as well. So ensuring that there are, as women are going through the life course, that experience is there for other people who've had that experience, is there for them to lean on. So I think I absolutely hear you. It is in there. We've had the needs of time to focus on some bits, but thank you. And yes, financial barriers, much harder because I think every country is different and there are different rules and regulations. And in the UK, we're lucky we have the National Health Service, and so the vast majority of these interventions are free at the point of delivery, but not all of them, and not for the most vulnerable in all countries. So how do we do that? And that's something that I guess place-based and whole area-based, that's a tension that we need to try and get right. And taking a rights-based approach, I'm absolutely with you 110%.
Thank you very much, Jane. I think, Giovanni, you wanted to say a couple of words as well.
Only as an Italian representative here, I really would like to make the voice that PrEP is an enormous contribution for the fight against HIV, and I cannot really understand how it's possible that within European Union there's countries in which, for instance, Italy, PrEP is not provided for free, contrary to all the rest of Europe. And so I think this is something we need to make our voice be listened.
Thank you, Giovanni. And Jeffrey, I think you wanted to say a couple of words as well.
Just very briefly, and really echoing on what Giovanni and Jane specifically said about financial barriers. I mean, when WHO, when the current Director General, Dr. Tedros, called for universal health coverage, I don't think he was really thinking about the European Union, because we should have universal health coverage here. And I think it permeates through all of the policy asks, that there should be no financial barriers. So I appreciate you mentioning specifically HPV, anal cancer. This was a highlighted issue at the Spanish National Conference just a few days ago I attended. But that's something we need to be working with, but really all patient groups, because in the European Union, we cannot have any barriers to healthcare that are financial, at least.
And interesting, we haven't really mentioned explicitly the Sustainable Development Goals and Goal 3 on health, universal health coverage, and I totally agree. In fact, there's a big challenge here in the European Union. It's not somebody else's problem either.
Yeah, Nick, I'll just mention a quick point on that. I hope he won't mind me mentioning, but when HIV Outcomes did meet with John Ryan, who heads public health at the Commission some years ago now, it was really explained that compared to the MDGs, the European Union really saw the SDGs as a priority, and that they wanted to measure it within the measure states and had committed themselves to all of them. So my understanding is that at least within the Commission, they take the SDGs very seriously, and that covers SDGs related to financial barriers, but also many specific health issues, including HIV specifically.
Terrific. Thank you very much. Coming back to Anton Bezenko, who is the ATG Programme Manager. And from your sort of lens, your prism, I'd just like to come back to some of the topics that we talked about a little earlier. HIV is thankfully no longer a life sentence, and the HIV population is larger than ever. What's your assessment through the work that you do, through your network of integration, inclusion, pervasive stigma, discrimination? Can you sum that up in a few words, Anton, please?
Yeah, exactly. Very right term to sum up, because I'm pretty sure that I will not say something revolutionary new now, but I will summarize based on my personal experience as a person living with HIV almost 20 years and person who used drugs more than 20 years, as well as based on my professional experience from the past, as well as now from my work in European AIDS treatment group as a quality of life program manager. So, hard thing to say that there is no one universal solution or receipt to completely overcome stigma and discrimination. But good thing, there are a number of well-known, proven and promising interventions and tools. But to use those really successfully, you should always follow very concrete principles. First is, of course, to work comprehensively on all levels and in all components or aspects of stigma and discrimination, whether it's a legal and policy changes or it's a change of attitude among, I don't know, healthcare professionals or other groups. For me, as a person who used drugs, I mean, the top two of the group who stigmatize and discriminate in us, it's the healthcare professionals and law enforcers. So actually, it's not only about doctors, as well as, of course, you should work with aspect of self-stigma with people living with HIV. So it's impossible. You cannot, for instance, promote U equals U without an undetectable and transmittable principle, without change laws that criminalize or discriminate people, like, for instance, prohibition of adoption of children or prohibition of access to in vitro additional reproductive technologies for people living with HIV, as well as you cannot advocate laws and policies but do not work with mental health or sexual and reproductive health and rights of people living with HIV. So when I say comprehensive, I also mean different kinds of approaches with all its diversity, trainings, working with media, campaigning. And second important principle is, of course, meaningful involvement of communities on all stages, whether it's decision-making processes or development of some programs. And of course, it's a community-led responses, community-based responses, peer-to-peer, especially in things like U equals U or working with mental health. And of course, human rights-based approach as a third principle. So, yes, it's not simple. It's a long way, and there is no fast magic solution or some magic bullet, as we say, but we have clear goals, including sustainable development goals and obligations from member states. We have support among policymakers, I do hope, and I mean, we hear it today. We have a group of committed partners, organizations, people, activists, and I think everything is in our hands and we really can do it. Thanks.
Great, thank you very much, Anton. I think you've brought this session to a close very, very beautifully. I'd like to invite all of our panellists to join the audience, if that's okay, and we'll move on to the next session. I'd like to invite Dr. Okay, so we need to swap. I'm just getting some information about some timing, and I think we're going to invite the two MEPs who are going to close to actually join me on the podium to say a few words of encouragement and support, and then we'll go back to our original programme, if that's okay. So it's good to be agile and flexible, and bear with me as chair. So please, you've heard a little... Just a second, because I'm finding my notes. Okay. Are you ready to rock and roll? Are you ready to make an intervention? Very good. So I'd love to introduce you, Sirpa Pietikäinen, EPP, Finland, extremely active on many fronts in the health field and also in the disability field. So what's your big takeaway, and how do you feel you'd like to move forward supporting what we've heard today, HIV outcomes and those very, very critical policy asks?
Thank you so much. And first of all, thank you for organizing this seminar and being so knowledgeable and active on this field. I remember in the early 90s when the HIV/AIDS had broken up, and we had first gala dinners in Finland to try to raise some funds for the research. There was can you imagine, a huge uproar. How can you go as a minister to this kind of an event? That is sort of a description of the discrimination and misunderstanding attitudes and everything we had only a couple of decades ago. So first of all, because there are so many challenges, I would like to pick up that positive side of the story. We have actually managed and proceeded with this issue hugely. Both in medical and research field, it's very positive that we have the treatment for HIV, but that we are moving from treating the symptoms and preventing the virus, actually for promoting good health, good life standards of the people. And this is the way I think that we very strongly should continue, and this actually should be part of the Commission's next health programme and work programme. Then, of course, the attitudes and the stigma were huge on those days, and this has substantially improved, as we know. But we cannot pretend that it does not exist still. And this is very important. It is, of course, important for sexual and reproductive rights, for good education, to have safe sex and all these fields, but it is even more important for the people themselves. Because we who are more engaged with this issue know very well that there is not a risk of being in contact with people with HIV/AIDS, but there's the risk if we do not do that. It decreases substantially the well-being of people when they feel not be accepted, not to be touched, not to be loved, not to be taken as they are. Or even though they would not be mistreated this way, if there's the stigma in the society, you all know there's the feeling, I might not be liked, I might not be accepted. So it might be better or easier if I do not outreach for other human contact, friendship, love, having family, and all the other normal features that quite a number of us desire in our lives. And that comes then to the other subject, and I congratulate very much raising this point, and this is the mental health. Of course, the COVID-19 has been a hardship in mental health in various fields, on the frontline workers of the health sector, for memory disabled people, old people, mentally challenged people. I could go on the list, but it has been a very challenging time for the people with HIV/AIDS also. It has been harder to get the treatments, it has been harder to get the support, and then again, if you combine the much higher risk what we have among those people with HIV/AIDS, of having anxiety, quite understandable, of having depression, of having maybe some other connected mental negative conditions that affect very seriously the quality of life, then that needs support. And now the question is that when we are having so many groups of the people needing the support, we really need to be fighting that people with HIV are not left aside and left behind the other groups, and sort of a thought that these might not be the priority, or these might not be the people so desperately in need of a support and therapy like the others. So I do hope to conclude that the next mental health program and strategy of the Commission that is promised to come will take a separate chapter and concrete steps and proposals how to take care of the mental health of HIV people also. Thank you very much, and happy to continue working with you in the future also.
Thank you, Sirpa. That's music to our ears. We discussed the specific policy asks in the area of mental health, and that's exactly one of the areas we wanted to pursue. So fantastic. I think you've made a really important point about ensuring there is a strong integration of the issues we've been talking about today in the next health programme, but also thinking about the next mandate of the European Commission, which is not so far away. Super. Thank you very much. Now moving to Sara Cerdes, as Social Democrat from Portugal. Yes. Please, the floor is yours.
Yes, I'm actually very happy to be here and to be able to give you some remarks now at this conference. And I would like to highlight the work that HIV Outcomes has been doing also on supporting us parliamentarians in not forgetting the battles that are still not conquered. As a public health medical doctor, of course, this is a dear subject close to my heart, as I had some experience working in the epidemiology of communicable diseases. And we had a change of paradigm in the last few years, in the last decades, and HIV is no longer a death sentence, it's a chronic disease. And what is of the utmost importance is to guarantee the quality of life for people, for those living with HIV. In this regard, I would like to reflect a bit on the study that was published on long-term well-being of people living with HIV. It was requested by the ENVI committee, and it was done by the CDC, one of our agencies. And in this report, in 2021, we had 106,000 newly diagnosed HIV infections, and this was a 25 fewer infections or fewer incidents when compared to pre-pandemic levels. However, this does not mean that there were 25 less infections. We're talking here about diagnosis. And just over half of those very likely that were diagnosed have been living with undiagnosed HIV for up to 8 to 10 years, and from those, 1/3 had more advanced HIV infection. I bring this number just to highlight the importance to have these reports, the importance, of course, you know these numbers so much better than us, but for us policymakers to take appropriate action and not leave this battle against HIV to just as a topic of the past, because this is still very much in the presence. We know during the pandemic why this happened. We had a pandemic that really hit the whole globe. We're now in the European Parliament talking about the lessons learned and recommendations for the future from COVID-19. And I hope in that report, where I am spokesperson for my political group, that we do not forget all the other diseases that were left behind, all the other undiagnosed people that were left behind. And now we have a lot of time to catch up. And this will obviously entail an important burden to the national health systems, which is a national competence. But the European Union, we have the competence, the shared competence of protecting public health. I would like to ask for the commitment to the 2030 agenda on 95% of people living with HIV knowing this status, not having people with undiagnosed so long during their life, from 95% of people who know their status receiving treatment, and 95% of people with HIV treatment to have a suppressed viral load. And another topic that my colleague already touched upon here, which is to be living with zero discrimination and stigma. We know one of the biggest burdens for the quality of life, one of the biggest obstacles is stigma, discrimination, and comorbidities. And we must put patients at the center of the healthcare systems, and in this regard, also account how we are going to deal with comorbidities that affect people with HIV. So I would just like to finalize thanking the HIV Outcomes for the opportunity of putting this conference. I have the pleasure to cooperate in previous editions, and I remember 2 years ago in 2020 we were talking about mental health, and still after this pandemic, or on the post-peak pandemic, let's not close the pandemic for now, we don't know what the winter will bring us, but just to reflect on how is our mental health after 2 years, and especially how is the mental health of people living with HIV. So thank you very much for your availability to come here and to discuss here to the European Parliament, and I hope me and my colleagues have a lot of homework to do here legislating for better health and well-being for all. Thank you.
Thank you very much, Sarah, also making the point how useful all of the evidence that has been gathered through the HIV outcomes work and beyond is helping to provide important ammunition for you to do your job. So that's a really encouraging message, and I think your clear support to what we're trying to do to move forward on the policy asks that have been discussed today really means a great deal. So thank you both very much, and I wish you well in the rest of your very, very busy days. Thank you.
Have me leave.
So let's now invite Dr. Andriukaitis and Baroness Barker and Dr. Strenu Scherschel to the floor for the last half-hour session. We've managed to secure a little extra time. We've got 30 minutes, so everybody will be able to have a voice. So it's a real pleasure to welcome Dr. Vignis Andriukaitis, HIV Outcomes Ambassador and WHO Special Envoy for Europe. We are really delighted that you're joining us today. And I have a couple of specific questions, food for thought for you. In your letter to Commissioner Kyriakidis and Chinas, you requested that the steering group on non-communicable diseases under your watch would be extended to include communicable diseases. And we heard today, it's been recently confirmed, that a new expert group will also address communicable diseases such as HIV. And what I'd like to ask you is why and how do you think discussions on good practices to really improve quality of life can be helpful to those living with HIV? In other words, the so what factor, why will it make a difference?
Okay, thank you. Thank you so much. I am so happy to be here today. And of course, you know, I just feel like a student because I learned a lot from previous speakers. So brilliant lectures, so good messages, so nice, you know, sentences. And I am so happy to say that I'm proud to being ambassador of such very strong group, HIV Outcomes. And when we are speaking about silver bullet, I think silver bullet is to have such strong HIV outcome team. You are such main, you know, main weapon to fight against stigma, discrimination, and so on. Okay, speaking about our activities, and I am very proud that we decided to establish a steering group on health promotion, disease prevention, and management of non-communicable diseases, and now including expert groups which are dealing with infectious diseases. It means that we can include and organize more synergetic efforts to analyze good practices, not separating, not avoiding silo mentality, because now we are speaking about what? About possibility to integrate HIV people into the same frame of discussing about quality of life, about possibilities to achieve treatment, to avoid stigma, avoid discrimination. It means that good practice can help us to understand better in very holistic, synergetic way, because we need now as never before to have a holistic approach to those people, not excluding them, not saying social specialization. No, it's not good. Good practice on the fight against viral diseases are mostly collected by, of course, by stakeholders, of course, by patient organizations, of course, by clinicians, but they must collect it together, encouraging different specialists to look into such very holistic approach. But I think it is very important now that good practice should be from how the impact of stigma or discrimination on mental health can be addressed with integrated care. Integrated care, once again integrated care, is very difficult work. It's very difficult to achieve in times of high specialization, because now you can see that navigate between those specializations is a very difficult one. We need to, the patient-centered approach means integrated care, and we have only one way to really encourage the good practice should be analyzed in the frame of integrated care. That's my approach, very simple.
Thank you. Thank you. That's really very helpful, and we'll be looking closely at how the working group actually evolves and has that integrated approach moving forward. Let's move to another topic, a very difficult and very painful topic, the war in Ukraine. People living with HIV, including older people living with HIV, are of course among those fleeing the war. Do you feel that there's been enough done to avoid the treatment disruptions and to really protect their well-being and their rights in the midst of all of this turmoil? What are your thoughts on that?
Yesterday I had good opportunity to discuss those issues with Anton, because Anton, he is from Ukraine, he's Ukrainian one, and he discussed a little bit situation in more details in this. Of course, can you imagine how is difficult situation today in Ukraine? We are here sitting, having light, having environment. And of course, heating, it's not so cold. And today, millions of Ukrainians are in so terrible conditions, including vulnerables and including people who are living with HIV. And those vulnerables are now, as never before, under such big, challenging situation. Stress. Not enough treatment, primary health care completely in disarray, completely. Nobody knows where 10 million people are refugees within Ukraine, and more than 8 million are out of Ukraine. And WHO estimates about 30,000 people with HIV are now between refugees. Of course, only one way is to raise this question, to raise European Commission attention, Council attention, Member States attention, because we need to address those issues now, immediately. Not saying, today we can focus more on helping Ukraine to fight on the battlefield, but now we need to also to do at the same time, with the same dedication to address issues with people, especially those who are in very difficult conditions. And of course, treatment, challenging issue. Of course, we need to raise one of the questions that it should be always high on the political agenda. How to EU to facilitate roundtable discussions? How can we implement our measures helping people between refugees and within Ukraine also? It's up completely. Now it's our obligation to do it.
And I think the idea of having this integrated approach of different players coming together to tackle that very specifically, very deliberately, and not leaving it for better, sunnier days is a really, really important one. It's fantastic that we have you as an ambassador. Thank you very much, Dr. Anku. We'll come back to you in a second. So we're now going to move to the national context, shifting a gear a little bit and see the national perspective. And it's wonderful to be able to welcome Baroness Barker, member of the House of Lords and co-chair of the all-party parliamentary group on HIV and AIDS in the United Kingdom. Thank you for joining us today. It would be super if you would be able to actually share with us the findings of the recently published report on quality of life that the all-party group actually drove forward, because I think there's also some really interesting learnings there. Please, the floor is yours.
Thank you very much for inviting me today. 40 years ago, I graduated from university. I noticed the sense of disbelief and shock amongst you. How could somebody who looks so young be that old? But I am. And I moved to London. And I was a young lesbian in London in the early 1980s. To understand what life was like then, perhaps maybe some of you saw the drama that came out 2 years ago, It's a Sin. I was Jill 40 years ago. And it was only a couple of years into that time of freedom and fun that my friends started to get ill, and then they started to die. And so people at that point started to live like there was no tomorrow, because for many of them, there wasn't. The big change came a bit later on, in about 1995, 96, when the protease inhibitors came in. And that was the game changer. At that point, people were going to live. We didn't know for how long, but they were going to live. And round about that time, I worked for an older people's organisation called Age Concern. And one day, one of my co-workers thought, do you know what? This virus doesn't discriminate on grounds of age. Let's go and have... But nobody's talking about this. Nobody's talking about older people. Quite rightly, everything was focused on young men, because it was largely young men who were dying. And when we went to look, 11% of people who had HIV were aged over 50. In the gay world, that's equivalent to being 100. Because when we talk about intersectionality and stigma, I've got news for you, the gay community was horribly ageist. So we did the first work in Europe, which was not clinical work, it was just social work. It was called Crisis of Silence, and we were looking at older people there. And I relate all of that to you because it explains to you why ever since I've been in Parliament, I've been a member of the All-Parliamentary Group. And why I understand that throughout these last 40 years, what has happened has been a shifting interplay between scientific knowledge, medical practice, understanding of community, and so on. And as Jane said, a change in the way in which we look at different patient groups. Back then, I worked for an organisation that worked with older people. Older people didn't argue with their doctors. Older people were just grateful to have anything at all. And then along came this bunch of young gay men who started talking to their clinicians and said, well, why? And I think the most interesting thing that's come out for me today is that we are again at a point of transition. And again, we are at a point when perhaps we need to be looking to form new alliances. And particularly those of you who have done so much in the field of HIV need to be looking at your colleagues who work in another part of the forest, and that's in older people's medicine. In the United Kingdom, we have a very, very good department of life sciences, biosciences at the University of Newcastle, where they have a longitudinal study of older people ageing. Not older people with HIV, but older people. And I've forgotten what the incidence is, but basically from the age of 60, your number of comorbidities and life-limiting conditions that you live with goes up and up and up. And we need to be talking to people like that, because one of our sponsors here today, as we might notice, Chiva. One of the important things that we're doing now is saying to a new generation of children, you need to have some role models of older people with HIV, because there weren't any 40 years ago. There really weren't. It's why, having followed on from our all-parliamentary group's reports on mental health and HIV, we have done this report, which is about quality of life. And one of the very first things that you'll see from the front of our report is that people with HIV are very different, very disparate group. They're not all the same. They're not all gay men. They're different. And that's the first thing that came out of our thing. Second thing that came out of our report was our data collection is really not granular enough. It's not as multifaceted as it should be. And we do need to be gathering data where we include lesbians, hello, we exist, thank you very much, bisexual women, transgender and non-binary people, and people from ethnic minority groups. And we need to be understanding this in a global context to be ageing in the United Kingdom, where, for all it might drive us nuts, we have got the National Health Service, is a world away from sub-Saharan Africa. We do think that it is important, as we come to understand HIV as a factor in a long life, that you can't separate out things like mental health and stigma and discrimination, and the fact that different healthcare professionals just don't get it. You may be the most brilliant physician in the world, but in your field, but the fact that somebody's coming to you for whatever it is that you do, and they've suddenly got HIV should not be in this day and age something that causes a problem. But clearly, to some professionals, it does. Picking up very much on the ECDC stuff, we all need to agree and come to a universal, and I do mean universal recognition, and I mean people in Africa as well, because we've got to keep them involved, about how we define quality of life for HIV. Because until we agree that, then we're just chasing each other around in circles. And in order to do that, we need to come to a recognition about the tools. I think Dr. Lazarus was very clear about that. Annual measurements. Yeah, annual measurements are important, not least because we are in a period where there is going to be a great deal of very accelerated medical progression. We're going to start talking about long-acting injectables, and we need to be able to know in real time what effect that is having on people's behaviour and on their behaviour. The technology appraisal bodies, yes, quality of life and health-related quality of life. We do it in other areas of medicine. We're not starting from absolute scratch on this, are we? We just need to take it and adapt it to what we're doing. And talking about stigma and discrimination, I'm now about to lob in something which is probably, I'm going to get shot for saying this, but I don't like the phrase you equals you. I think that you equals you is a bit technical, and I think it means quite a lot to people who understand and live in the world of HIV. I think talking about the fact that people can't pass it on is something. We need to get the you equals you message, but say it in different ways for different audiences. Yeah? And I'm not saying one's right and one's wrong. I'm just saying that there are different audiences for things. So all of that leads me to say thank you very much for listening to what we've had to say. And I hope that at a national level, you will see that we have picked up on a lot of the thinking that you've been doing on a European level, and we're trying to make sense of it within one health system.
Thank you. Thank you very much for that stimulating talk, really picking up on so many things, the crisis of science back in the day, the importance of intergenerational solidarity, the global agenda, which I think is very much a topic here in this town at the moment, data, getting the data right, diversity, equity and inclusion within the movement, and the key point of messaging. Thank you very much, Baroness. Last but absolutely not least, it's a great pleasure to welcome from beautiful Romania, Dr. Anca Sternu-Cercel, PhD senior lecturer at Carol Davila Medicine and Pharmacy University, and a clinician at the National Institute for Communicable Diseases in Romania. So, a key question. I think we've talked about it a little bit, but it would be great to crystallise it now. Why should we be starting to think about the person behind the disease, not simply the disease itself? And what could we learn from the Romanian health and care experience, where an important cohort of people living with HIV been living with HIV for over 30 years. You've got huge experiences. We had a great conversation yesterday evening. So, yeah, I'm really curious as to what more you'd like to share with the audience, please.
Thank you so much. Thank you so much for asking me to join the meeting, this outstanding meeting. And thank you for the introduction. Yes, and with all the intervention from this morning, the stage is set up for HIV and for understanding HIV. As you mentioned, last but not least, my intervention is Romanian perspectives, talking about patients, so the patient beneath the numbers when we are talking, because for Romania we are talking about 20 million inhabitants, but for that we are talking about an estimate of 90,000 patients, and for that around more than 30,000 in medical care, engaging with doctors, engaging with medical personnel. And my main focus point that I wanted to touch today is that half of that cohort of 30,000 patients in medical care, so around 7,000 of them, are from the so-called former pediatrical cohort from Romania. So when I got interested and engaged in HIV was in the late 80s, early 90s, when a big cohort of children living in Romania got infected with HIV, not from mother to child transmission. So half of them are still alive nowadays due to really dedicated doctors at that time point. Some of us are with us here and some are online. And I really like to thank them from the point of view of a young physician working in the field for 20 years, but these patients are alive due to their intervention at that time point, because as it was already mentioned, at that time point it was a deadly disease. So life expectancy less than 6 months, and to do that from the point of view of a young children, age 3 or 4 years old, with healthy parents is a totally different perspective. So due to that intervention, they are here, more than half of them living with us in medical care, still sharing with us their perspectives. And for that kind of population, we need to look at it from different point of view. From aging, as Professor Guaraldi mentioned, because they are young by age, but old by treatment. Yes. So we should look at that age group around 35 years old from a totally different perspective than from a younger perspective. So I am not only talking about them because we have another half of the cohort, which are usually matching European cohort. So again, struggling with the same debate that we have talked today with stigma and with comorbidities and with age and with getting older with HIV and so on. But we have two cohorts that engage itself, and we have two perspectives looking at our patients. With some of them we grew up, and we grew up as physicians as well, and they grew up with us. So they are really people beneath their number, and for each of their physicians, they are really a history, a life, a journey taking with them, growing up with them, and now facing different challenges. And one main factor, because we have touched on reproductive diseases and so on, half of them are women. So they want to engage in getting families and engage in a normal life. And what means normal, it's a little bit totally different from what means normal for a patient that is not touched for HIV, so to say. So it's really important that in 2022, in our country, we are offering a perspective about what's going on. So I really welcome the invitation of being here, talking about them and putting them into a perspective of European perspective and the challenges that will come along will really be important for them and for us as treating physicians. So thank you.
Thank you very much, Anka, and it's clear we have a lot to learn from your vast experience over the years accompanying children, young people, and now older people living with HIV. So thank you very, very much for coming today. It remains now for me to thank once again our host, MEP Ries, our excellent speakers, and the Secretariat and the Outcomes Steering Group, HIV Outcomes Steering Group. The audience, of course, you've been very indulgent and patient with some of the technical challenges, but I think the richness of what you've heard and shared today has been definitely worth it. We've had a fantastic, wide-ranging meeting with consensus and alignment on the need to move forward on critical policy asks for the HIV community. And I sense that this is simply the start of a new adventure. A huge amount of progress has been made so far, but we still have a lot to do. We have the open ears of parliamentarians in this House, and we have considerable support from the Commission and the Member States, and this bodes very, very well for moving forward. So with that said, I would like us to remember the key messages from today and keep them alive by using the social media, following HIV Outcomes on their media, Twitter, LinkedIn and YouTube. And now we'd like to invite speakers and you as the audience for a lunch, a seated lunch in a brasserie in the European Parliament. And it's a little tricky to find, as things tend to be in the European Parliament. So the organising team will lead you to your lunch. Thank you all very much. And the report and all of the follow-up from the meeting will come to you shortly. Thank you. Thank you. So much. I'm sorry we had to shorten this a little bit.
Yeah, of course.
The important messages were great.
Excellent. Your job was really brilliant.
Thank you very much. Thank you.
Thank you so much. Really a pleasure meeting you.
It's a pleasure meeting you. I'm sorry we had to do a short meeting. You're so patient.
Thank you.
This meeting is no longer being recorded.
I understand we need to leave this room fairly promptly, and we can continue the networking at lunch if that's okay with everybody. Thank you.